Good morning. Welcome you all to this program. It's been a very pleasant day here in Chennai, and we all know that we've started the Society for Vaginal Surgeons of India. Even though we have been doing it for centuries together on vaginal surgeries, it was recently just started under the able guidance of Dr. P.C. Mahapatra. And in Tamil Nadu chapter about 5 months ago, we started it under my leadership with Dr. SEQUELAE as the secretary here. And it's we just started the initiative, and then we will keep the ball rolling. All of you can just take over the leaderships and just create a very good platform to share your views. Here, we have had a wonderful launch meeting followed by another meeting with Dr. Meena Umachandar. And then after that, we had another good program from Lily Varghese. And with that, we just went on to just do this program today. And we have great pleasure is inviting an international faculty, a well-renowned man in the Urogynec, Dr. Ajay Rana, as a visiting consultant and visiting faculty. And he will be a global representative, not only an international speaker. He will be a global representative going to give us some global message for us on the incontinence. And without much ado, I invite Dr. SEQUELAE to start the program and introduce the speakers.
Yes, sir. Now, I would request our Director ISO KGH, Professor Kalaivani Madam, to give her felicitations.
Good morning to one and all. It is indeed a great honor and pleasure to offer my felicitations to the Society of Vaginal Surgeons. This society is doing a commendable job and is offering great service for all our gynecologists. Though they had a very short period, they just started the program 3 to 4 months back. They have done 3 to 4 webinars, which has been well appreciated by our colleagues all over. I wish the society, headed by our beloved president, Dr. P.M. Gopinath of the Tamil Nadu chapter, and Dr. SEQUELAE, who is my friend for past 23 years, I think. They are doing a very good job in conducting all these programs. I'm also very happy to invite speakers, Professor Muthulatha Madam and Professor Ajay Rane, who had wished to participate in this program. And I think as Dr. Gopinath has will give us a global view of the problems in urogynecology. At this juncture, I also like to invite Professor Ajay Rane, who had always been a faculty, our own faculty at KGH ISO, and I had seen him conducting so many programs. I wish him once this pandemic is over, probably by June, we will see you doing a live workshop at ISO KGH. Thank you, sir. And I like to invite the speakers for this session, and I hope that this SOVS society will go a great way in offering service to all our gynecologists. Thank you, sir.
Unmute.
Thank you, Madam Dr. Kalaivani. Thank you. We now start with the scientific session. May I now request Professor Muthulatha, who has been a wonderful teacher, to talk to us on the prevention of bladder injuries. She was a professor and head of urology in Madras Medical College and has been a teacher for teachers. And she's presently the professor of urology in Savita Medical College. Over to you, madam.
Yes. Thank you, SEQUELAE. Can you hear me now?
Yes, madam.
Good morning, everybody. And at outset, I thank Professor Gopinath, Dr. SEQUELAE for giving me this opportunity to share this platform on behalf of this society. Thank you so much. Yeah, we go to the topic prevention and management of bladder injuries in obstetric and gynecology. Yeah, bladder injuries are not at all a new one. This from ancient time onwards we have got this. Is it a nightmare? Definitely not. Once you know the knowledge about the anatomy of the bladder and the thing along with the genital system, we will not have any problem in handling any urinary bladder injuries. So you should know about the anatomy very well. And I know very well that you all know how the uterus and bladder will share a close proximity to each other from all the thing in all surfaces of the bladder, from the anterior cord and the superior surface and to the base of the thing till it enters into the urogenital diaphragm, how it has been related with the base of the bladder and the space of ridges. So in any way, from catheterization onwards, we can injure the bladder unless we know the anatomy very well. So going to the, and it has a very good blood supply. This blood is a very vascularized organ. So however you cut and however it gets torn, and if you suture it will regain it back to its normal. So going to the bladder injuries, as I said, from the ancient time onwards, it has been documented very well. And it has been, it's important for us to locate the bladder injury where it is and what type of injury we are dealing and how it has been performed, whether it's nitrogenic or non-nitrogenic. So as far as obstetric and gynecology, we have some risk factors. Let us know a few of them. So we have a distorted pelvic anatomy, maybe due to a congenital thing. Suppose when you are taking the patient for emergency LSE, suppose the patient has a pelvic kidney, we'll be little bit confused what we are dealing with. And other things like a huge cervical fibroma, which will distort your anatomy. And previous pelvic surgeries, anything, any general studies or a laparoscopic surgery or any gynec surgeries, and a chronic infection and inflammations like endometriosis and abdominal tuberculosis, where the ventry will be very, very difficult, as you know, and extensive pelvic adhesions like previous irradiation or a chemotherapy, post-chemotherapy, where the desmoplastic reaction is quite high, and pelvic malignancies like and radical surgeries. And when you come to obstetrics, it could be an arrested labor in a second stage. Of course, now it's very uncommon, and like a adherent placenta. So this already we have seen this distorted pelvic anatomy, how it has been deviating the bladder anatomy and the uterus. And this placenta, and especially in a placenta pericreta, deliberately you have to do a cystotomy before delivering the baby. So we need to have a preoperative counseling with the patient. So according to European Association of Urologists, the incidence are quite high with the malignant surgeries, especially with the lap and robotic, as it will go as high as 5%, and the vaginal hysterectomy is the least one, up to 0.6%, and the cesareans, it may be 0.08 to 0.94 when it goes for repeated LSES. So in LSES, when it goes for an emergency or a repeated LSES, or when an LSES being taken up for an arrested labor or a failed trial labor after a cesarean, the injuries may be little bit increased. And then it will be common when we are entering into the peritoneal cavity. So during entering into the peritoneal cavity, or if you want to create a bladder flap, or when you are going for an uterine incision or delivering the baby, the incidence may be more in a repeated cases. So there is no statistical difference what type of incision or induction of labor or with the maternal illness or a fetal position. But the incidence already we have seen, it could be in a hysterectomy 1.27%, and the risk factors we have seen. And in a pregnant uterus, when you are going for a cesarean hysterectomy in a case of ruptured bladder, we will not be knowing what anatomy we are dealing with. At that time, the incidence is little bit more. So how to identify? Intraoperatively, how to identify it, and postoperatively, how to identify a bladder injury. So this is the most important thing. We should have a high index of suspicion. So you have to identify and what type of injury we are seeing, and according to that, the surgical correction or a conservative management, whatever it is. So what is the mechanism of injury? How it can be done, this bladder injury? So more and more lap surgeries are coming now. So due to venous needle, when you are putting a needle or a trocar, when the bladder is not getting drained properly in a distended bladder. This can happen, or during a cystotomy when we are want to develop a bladder flap, or during a dissection or a dialysis with an endoscopic or a blended dissection or with a cautery, you can injure the thing. And in a second stage of labor, this is what I think, when the bladder is getting compressed in between two hard objects, anteriorly by the symphysis pubis and posteriorly by the head of the baby. So this will have a pressure necrosis at the level of bladder duct and result in a very bad VVF. So we have seen what all the risk factors. So whether we need a preoperative urological workup before going for a gynecological surgeries. And as such, we don't need, unless otherwise you go for a malignancy where you go for a workup. At that time, you can have a contrast study. Otherwise, we don't recommend any routine cystoscopy or a routine CT scan or thing like that. You don't need a preoperative. Unless otherwise you need, we can go for a stenting and thing according to the case what we are going for. So what are the, now is the time how you'll be, what are the signs you have for a intraoperative bladder injuries. So when you are doing, suddenly there is a gush of fluid in the surgical field. So you have to suspect whether we are having any bladder injury or not. Or what you are seeing in the video clippings, like a visible laceration or the Foley bulb. So this is so definitely a bladder injury. Or when the anesthetist says there is a hematuria in the urine bag, or during a laparoscopy there is a hematuria, then you have to suspect. When you see a Foley bulb or a laceration, yes, you are dealing with the case. Suppose if you are suspecting, how to find out? So there are some tests. Nowadays, all the theaters are provided with all gadgets. So now you have a methylene glow, what you are using for your other things. At that time, like fallopian tube block and all. So you'll have a methylene glow. So you have a methylene glow with along with saline. You through the urethral Foley. All the time you'll have a preoperative Foley catheterization. So at that time you instill some amount of around about 100 ml of methylene glow. That will give you a thing. See, this is how this will stain, and it will show that definitely we have a bladder injury. Otherwise, nowadays you have a flexible cystoscopy everywhere. So even it can be applied during supine position also. So the cystoscopy will tell you how the bladder injury, so that you can visualize the bladder injury through the thing. And the same time, the proximity of the bladder injury near the ureteric orifice or the trigone or the bladder neck, anything can be seen. And this is another method. So now almost all the theaters have a facility of a CM. So when you are in a doubt, so you have a contrast field. You instead of methylene blue, you instill contrast filled saline, and you take a picture, you shoot a picture that will tell you whether we have a bladder injury. If at all we have a bladder injury, what type of bladder injury we have. So intraoperatively, we have these methods so that we can say whether we have injured the bladder or not. So these are all the preoperative, intraoperative signs and the methods to find out what are the bladder injuries, whether it has occurred or not. So coming to post-operative, there are some signs we have. So when you have a hematuria, normally also you have a hematuria at least for 24 hours. When it is persistent for more than 48 hours, or the hematuria is getting intensified, or if there is a increase in the drainage tube fluid, or there is a leak of fluid through the abdominal wound or the vaginal wound, or there is a fever or a flank pain or a paralytic ileus or abdominal distension or a evidence of peritonitis. And sometimes you have a acute renal failure. Most of the intraperitoneal rupture will pick up the patient in the department of nephrology undergoing hemodialysis. That's what we have. Many patients of intraperitoneal rupture has been picked up in those conditions only. So these are all the some of the signs where you have high index of suspicion of thing, you have to suspect. So again, the same way, either a cystoscopy or a cystogram. A CT cystogram or a conventional cystogram will give you a clue what type of bladder injury we are going ahead. So with this, we can find out the bladder injuries. So once you find out the type of bladder injury with the cystogram, whether an extra, a cystography is a retrograde filling of the bladder with a minimum volume of 300 to 350 ml of dilute contrast material, and with that we can shoot up the pictures and we can see what type of injury. So according to the American Association of Trauma Surgeons, either it could be a contusion or an interstitial rupture of bladder, or an extra or intraperitoneal rupture, or a combined one. So this is a radiological feature. The first picture will show there is no contrast extravasation, but patient may have a hematuria. This is only a contusion. The third picture again, it's only there is no extravasation. That whatever you are seeing is within the bladder. It's an interstitial rupture of bladder. The fourth and what you are seeing, the fourth, the extraperitoneal, you are seeing the bladder. Above that, you are seeing the extravasation of contrast. The last one is a combined one, intraperitoneal and extraperitoneal. With this, we know what type of injury we are going for. So according to that, the management also differs. So the sequelae, all of you know what will be the sequelae of a bladder injury if we don't identify it or missed. So management, when we go for whether a conservative management is there, definitely there is a conservative management. What are the conservative management? It goes for either a contusion bladder or a interstitial rupture of bladder, or a very small, when a bladder injury due to a virus needle or a trocar injury, or a very about in a dome of the bladder about 4 mm. This needs only a conservative management. You catheterize the patient with a large bore catheter. That is usually we will catheterize with 20 French Foley catheter at least for 14 days. That will allow the bladder to get rest and heal, and that will be the. So this is a conservative management. So the other things, you go for a repair, surgical repair. The surgical repair either for a open or a laparoscopy. If you are doing a laparoscopy, when you are finding out, yes, through laparoscopy itself, you can go for a repair. Otherwise, you go for a open. So what are the points? So when you are going for an open repair, suppose you are doing a cesarean or a hysterectomy and you think that is a thing, and we have found out during intraoperatively. Initially, you finish off your primary surgery, whatever it is, either a hysterectomy or a cesarean. Then you don't be in a panic. You inspect where is the rent and whether it is associated with any other injury that is near the trigone or the bladder neck, or so site is very important, size is very important, whether it is associated with the bladder neck or the urethral openings are very important. Always, as a urologist, we'll go for a 2-layer closure. So the first layer should include mucosa. Definitely the mucosa should include it. Mucosa, submucosa and seromuscular in a continuous fashion. Then you take a second layer as a seromuscular layer. So at the end, you go for a hydrodistension, which is mandatory. You instill some amount of saline through the urethral foley and see for any leak. Any obvious leak, you superimpose to the suture. And it will not give not only a leak from the suture site, and it will give, suppose if you miss any other injury, that also will be given. Always you catheterize with a large Foley catheter, preferably 20 French. Definitely a female urethra will accommodate a 20 French Foley catheter for nearly 2 weeks. So whether when you go for a SPC, all the cases you need SPC, definitely no. So very clean cut. If the injury is in the dome, a small anterior wall injury, that doesn't need. You close it in 2 layers. You catheterize with again the 20 French Foley catheter. That's enough. Otherwise, in an unhealthy rag, which is when you are having more uses of diathermy, suppose as you said, when you are going for a ruptured uterus with the going for a hysterectomy, at that time you may not know how far it has been torn. Those times you need to have a SPC, because if you put a SPC, you'll have a peaceful thing, because sometimes in a gross hematuria patient with the gross hematuria, kindly you put a SPC, because even a small clot will obscure the blockade in the lumen and leading to retention, then the whole thing will go off. So always you put, when you have a gross hematuria, kindly you put a SPC. So this is how. Always you put a SPC not through the cystotomy wound. It should be a separate stab injury through the bladder, and again you don't bring it through the main abdominal wound. It should be away from the abdominal wound. As far as in a phantom slit incision, let it be in a midline. So need for double J stenting. Suppose if the injury is very close to any ureteric orifice, then there may be. Otherwise, there is no need for double J stenting in a case of bladder injury repair. So in laparoscopy also the same thing. Only thing here, mostly you'll go for a single layer closure. but you should include mucosa, muscularis, and serosa. And if you are able to get a omental graft or a peritoneal thing, then you place it in between the suture lines. Otherwise, there is no need. So what is very important? One is a large bore catheter, and second is a continuous bladder drainage. Please don't clamp it, and always you keep it for at least for 2 weeks. At the end of the second week, you do a cystogram. You ensure the whole thing has healed. Then you pull it off. If you have a SPC, you remove it at the first week, end of first week, and strap it. Then you remove the urethral folae after another 7 to 10 days. So this is what, in the 5 to 7 days, SPC to be removed, and 14 days the folio to be removed. Always you do a cystogram to confirm the healing. So this is how the risk of bladder injury is reduced by emptying the bladder. Always you keep it in a bladder at rest, and this will aid in identify the bladder. And always you do a meticulous sharp dissection and use your cautery with the careful when you are going for a wall suturing. And this role, you know how to go with a post-cesarean hysterectomy from lateral to midline so that you can avoid a bladder injury. You'll be knowing better than me. And this role, they say double layer closure of the uterine closure is better than a single layer. They say there is a 7-fold increase in the developing bladder adhesions if you go for a single layer, but it is a surgeon's choice. And this is peritoneal closure. Again, is the controversial, even though each study shows different one. But as a general surgeon, always I'll go for an anatomical closure, and I'll ask my people to go for an anatomical closure. And again, these are all the studies. If fantasy is more better than the vertical, and if you go for a creation of a bladder flap, again the incidence is quite high. Already we have seen all these things. So what the EAU, that is European Association, has recommended as far as bladder injury in common, whatever it may be. See, what they say, you perform cystoscopy as far as urogynecology, you perform cystoscopy to rule out any bladder injury during preoperative sling surgeries. That is definitely you have to do it. That's a recommendation given by the EAU. So otherwise, once we missed, we know what happened to that, and it will be a painful thing for both for the surgeon as well as the patient. So to summarize, you have a preoperative counseling. Suppose if you are having a patient with the placenta pericreta, you counsel the patient preoperatively, or if you are going for a malignancy, you counsel the patient, and you have a planning and get an informed written consent and all other things. What I say, preoperative catheterization and a prompt intraoperative identifying the bladder injury and what type of bladder injury and associated injury also to be assessed, and go for a proper watertight closure with the placement of SPC according to the injury, and thus we can prevent the bladder injuries. Thank you so much.
Thank you, Madam. Madam, as usual, your talk was very clear and crisp and carried home all the important points. It was really lovely. Thank you. Thanks a lot, Madam.
Thank you. Thank you. Thank you.
Thanks a lot, Madam. Now, the next talk would be by the renowned international speaker, our star performer always, Professor Ajay Rane. We all know in this COVID era, we are having a lot of webinars. And even today, we know that we are having a lot of webinars. Professor has to join another webinar. So he didn't want to miss our program. So we would request him to give his talk now. Professor Ajay Rane does not require any formal introduction. He is almost like our own faculty of the Gosha Hospital. In Gosha Hospital, his name is very popular, not only among the professors, students, but even among the working class of people also. May I request Professor Ajay Rane to join us and give his talk. Over to you, Prof.
Thank you. Thank you so much. Just making sure that I am heard, which is, I think I am. So first of all, Vanakkam, and please don't call me international speaker. I am really part of Gosha. So really, I am a local speaker, not even a local speaker. I am a local speaker. Professor Gopinath and Professor Kalavani, thank you for your warm words and your warm welcome. And Professor Mutlada, always lovely to see you. I have been to Savita Medical College, believe it or not. I think they didn't tell you that I had visited, but I have visited just before COVID hit Chennai. So a wonderful institution. So lovely to see you on a fantastic lecture. It is surprising. It is surprising. Doesn't matter how many times you listen to people, you will always learn something new. So this is very important. Today I learned something new from Professor Muthulata's lecture. So you will always learn. I just want the participants to understand, irrespective of your age, your seniority, your technical ability, you will always learn if you keep your mind open. So this is what I would probably, the youngsters, if I can tell you this much, keep your mind open always. Don't say I've learned everything, I know what to do, because you'll always learn more in life. And that I think is very important. So I've got a very bland topic, which I'm going to try and make a little interesting if I can. I have got 20 minutes to do that, and then a 20-minute talk on a little bit more diverse looking at the world. So let's go. I think that if you contemplate any gynec surgery, leave aside urogynecology, I'm not going to use that word. I'm going to just say gynecological surgery. You must know where the bladder neck is. You must know where the ischial spine is. You must know where the perineal muscles are and where the puborectalis is. They are two different structures. And you must be able to gauge what is the subpubic angle. Is it below 90 or above 90? If the subpubic angle is above 90, vaginal surgery becomes easier. If the subpubic angle is acute, it's 90 or below, you will have the vaginal surgeon always shouting at the assistant because there is not enough room. So you are already thinking in your mind, what difficulties may I face when I'm going to operate on a patient? But if, as Professor Muthulata said, it's anatomy, anatomy, anatomy. The more anatomy you know, the less problems you have during surgery. And we are not very good with our anatomy, because once we finish first MBBS, we don't want to ever go back to anatomy. It's the anatomy that will always save you, especially when you have complications. Some people ask me, you talk of this trial of void, trial of void, trial of void. Who should have it? And I sincerely believe that it doesn't matter, actually. Even orthopedic patients need trial of void because the bladder gets paralyzed with pain. So if you look at my part of what I do, I will say, if you do a sling operation for incontinence, you do a trial of void. If you especially operate on the anterior compartment of the vagina, be it laparoscopic, be it transvaginal, be it transabdominal, do a trial of void. Perineoplasty is a different repair to posterior repair. So if you repair the perineum, it can be quite painful because the level 3 part of the vagina has got enormous nerve supply and blood supply. So pain in itself may cause urinary retention. So you need to do a trial of void because, as a urological professor who's sitting here will tell you, if you have more than 8 hours of neglected retention of 1.5 to 2 liters in your bladder, you can sustain permanent detrusor damage. Permanent. That means you have to either self-catheterize or wear a retropubic catheter. So it is very important for you to understand that even after a traumatic vaginal birth, maybe instrumental delivery, 3rd or 4th degree tears, epidurals, you must check that the bladder is emptying properly. Because if you neglect it for more than 8 hours, And if there is more than 1.5 to 2 liters of urine in the bladder, you can get permanent detrusor damage. So that is why you've got to be very careful. How do we do it is something I'm going to share with you because we are obviously a very urogyne focused unit. But all I'm saying is we just try and put together some communication. So the first thing we do is, as Professor Mutulata said, talking about basically consenting the patient when you anticipate difficulty, we call it instructions for use. So we tell the patient what is going to happen to them post-operatively before you do the surgery. So if you tell the patient when you wake up, you're going to have a catheter or you're not going to have a catheter, whether you're going to have a vaginal pack or you're not going to have a vaginal pack, whether you're going to have sutures on the perineum or not, it stops the patient being anxious. So they are prepared that when I wake up, there is going to be a catheter and a bag, or there is going to be no catheter and a bag. We also talk about something very simple, and that is proper posture on the toilet. Now, even in Chennai, I know that a lot of people have moved from the wonderful Asian squatting toilet to the Western throne. And we just seem to get lazier and lazier, but that's life. But so it is very important if you're using a Western toilet to understand how to sit on the toilet, make sure that your feet are flat, that you have foot support, that you lean forward. All these things are very important. Most of our counseling is done by a nurse. It doesn't have to be a doctor. So sometimes you feel, oh, I'm so busy. You can get a fantastic nurse who will do the counseling of the patient. The other important part is when the patient does not void, usually what happens is the relatives and the nurses will keep giving more water, more thanni, more water, drink until you are going to burst. You have to, that does not force the patient to void, because the voiding mechanism is a neurological mechanism, not a bladder distension mechanism. So giving more and more water, in fact, distends the bladder beyond its capacity, and then the patient can't void anyway. So restrict yourself to between 100 and 200 mils per hour when you either remove the catheter or you have a trial of void going. I think most gynecologists have an ultrasound scan. Most of you, probably 100%. It's not very difficult to just put a probe on the abdomen and measure the volume in the bladder. It's all done for you. All you have to do is 3 arrows and it calculates the volume. Keeping the patient pain-free is very important. You cannot expect a patient who is in pain to void. In fact, one of the diagnoses that we have is if they ring me and say, Professor, patient is not voiding, especially post-instrumental delivery, I will say, okay, you need to drain the vulval hematoma. And they look at me and say, what are you talking about? And most of them will ring me back and say, how did you know there was a vulval hematoma? Because the patient is in so much pain, she's rolling around, morphine is not stopping the pain, there has to be something wrong. But the last thing people want to do is do a PV examination. Something that we need to get over. We need to do internal vaginal examination if you suspect that there is pain beyond what normally should occur. These are very open communication channels that you should keep. So your juniors should not be scared to contact you. Normally, it wasn't the case like that. We used to be very scared to ring our seniors because we knew that might cut our head off. But I think it is important as you get older that you learn to tell your juniors to have open communication. If the communication lines are open, actually they don't contact you. But if the communication lines are closed, they worry a lot and make mistakes. So if you just keep the line open, just tell them, call me if you have any problem. They don't call you because they're managing, they're confident that there's always someone I can ring. So this is one of our leaflets. You can go on my website and get this out. It just talks to, this is for the patient. Well, this has been translated into many languages. It basically is a very standard little piece of paper that we give our patients before they have even a vaginal delivery. Just tells them what a trial of void actually means. You know, they think this is some big scientific thing we are going to do. All we are going to do is ask them to sit on the toilet and have a void. But they get very worried. And so it's always good to give some pre-delivery or pre-operative information so the patients actually have understood what happens. The last bit is very important. It says, don't be disappointed if your trial of void is unsuccessful on the first attempt. Voiding is a very much a psychological and a physical combination. It's a very weird combination. So patients can immediately lose hope and they go, oh, I only came to have my baby. Now I can't void. What have you done to my bladder? Everything just goes. So you got to make sure that you tell them, don't be disappointed. It all comes together, but you need to understand what you have to do. We started by putting pictures in the antenatal ward. We used to always say, if you're using the Western toilet, it should be like you are reading a book on the floor. You can see the book is on the floor, not in the hands of the woman. The book is on the floor. So they're leaning forwards to read the book. That increases in intra-abdominal pressure. My PhD is actually on posture and micturition. And it tells you that the Asian squatting technique is the best in the world. But if you've given up that wonderful technique, then you need to be very specific on the Western toilet. You must have your feet flat and you must lean forward as if you're reading a book on the floor. And this is a device that we have invented, but you can put like a book or 2 bricks to lift your legs up above your anterior superior iliac spine. That increases intravesical pressure passively, opens your levator hiatus, and helps people void better. So this also can be done. It's like having foot support. So just to probably take you through a little bit of detail what we do. So we always say that 0 hour is called T. So all trial of voids to commence T plus 2 hours. 2 hours means either when you remove the catheter or when the patient arrives in recovery. That is T, or 0 hour as we call it. So immediate, don't let it go more than 2 hours. You know, the patient is like sitting there and you have to, they ask, do you feel like passing urine? Do you feel like passing urine? Do you feel like, and then they stop asking. So at 2 hours, you actually make the patient go and void. And that, I think, starts the whole process of confidence. Oral intake is 200 mils only, not more than 300 mils intravenous till trial of void has passed. So like I said, please refrain from asking women to drink lots and lots of water to flush it all out. Commence your trial of void even if patient has no desire. So sometimes they just sit there. You want to pass urine? No. Do you want to pass urine? No. It doesn't matter. It's 2 hours. Go. You have to go. You start the process. Otherwise, the bladder gets over-distended and they don't void. So I know you think this is very simple. This has taken nearly 7 years of research to put all this together so that you can have a good understanding. So you have to ensure that the patient is pain-free. That is very important. And I also told you that you ensure that they adopt a proper position on the toilet. Believe me, we have done more than 7,000 slings now. We have a 97% passing rate with trial of void. So, but it is all about communication. It's not the skill of the surgeon. It's not the skill of the anesthetist. It's really all about counseling. And if you counsel properly, most of your patients will pass urine and there'll be no problems. So we have this algorithm, which is a bit busy, but please feel free to take this, from my website. It actually gives you just what would you do if you have a day patient? What would you do if you have overnight patient with a catheter? And how we would manage the trial of void in case the patient does not void, okay? So this is basically instruction to the nurses. And the issue is very simple. If you give instructions to the nurses, they are not always ringing you to find out what's happening. Same way you can give these instructions to junior doctors so that they're carrying this piece of paper so they don't ring every time. Oh, this has happened, what shall I do? This has happened, what shall I do? It's all written there clearly. So for postnatal bladder care, which was another part of my talk, we see the issues with voiding occur after catheterization. So you put in a catheter, and it's a very interesting. I know there must be a few obstetricians in this group, Srikala. So the issue I have a question is, if a woman is giving birth vaginally, do you deflate the balloon in the second stage of labor or not? So that's the first question. And the second question is, in labor, if you have to put a catheter in, what is the size of catheter that you would look at? I will give you the answer at the end of the slide, so don't worry. Second part is the epidural. If you have epidural or spinal, the motor function of the detrusor is the last to come back. Motor function is the last to come back. So we are talking of, if you discontinue the epidural, the catheter should stay in for at least 6 hours more, because the motor function is the last to come back. Even your sensory function might come back, but the motor function is the last to come back. So what happens is the woman will not have any sensations. The bladder will get bigger and bigger and bigger and bigger, and they get overflow incontinence. So basically the urine just passively is flowing out because they do a little bit of straining. And then what happens is you say, Amma, did you pass urine? Yeah. They say yes, but you haven't really actually checked whether they have passed urine or was it urine that's overflowed. And that is a big risk for permanent bladder damage after delayed retention of urine more than 8 hours, more than 1.5 to 2 liters. And that detrusor will never, ever function back again. You'll always have a hypotonic detrusor. So it is very important. We see not a lot, but we do see young women who have just given birth have permanent bladder damage and who either are self-catheterizing or need a suprapubic catheter. It is very sad. So we need to be very vigilant. You do get, if you have a neurogenic bladder, you can also get neglected retention. So I think, how would you create a neurogenic bladder? You would create a neurogenic bladder because you actually allowed the detrusor to overstretch, and therefore the sharing of the nerve fibers to each detrusor muscle cell fiber is disrupted. And that's why you get a neurogenic bladder. So we don't want that. So it doesn't matter if it's one patient in a unit that delivers 14, 16,000 women. It's a terrible tragedy for that woman. So please, postnatal bladder care is very important. And finally, I think this is the algorithm we have. The algorithm is basically to make life a bit easier. I think people just go, so what used to happen was people used to ring me and go, Professor, she has passed 120 mils. The residual is 70 mils. Is that good? Professor, she's passed 250 ml. And I'm saying, excuse me, I do 20 slings a day. If you're going to give me 4 phone calls per patient, that's 80 phone calls within like 4 hours. It's going to kill me. So we said, no, we're not taking any more phone calls. You are going to follow this algorithm. And the algorithm basically divides patients into 4 categories. Category A is very simple. Passes more than 200 mils of urine. Post-void residual is less than 100. Done twice, go home. Patient D is, and patient C, I want to talk about, that's the easier one. This is called the half and half. So patients emptying 200, retaining 200. Patients emptying 250, retaining 200. But they are passing very good volumes, at least more than half of the bladder volume. Such people, you could put a catheter in for 48 hours, but I believe that they are called the half bladder emptiers. If you ask them to do timed voiding, you can review them in a week. No need to put a catheter, no need to self-catheterize, nothing. It usually settles down. So I like patient A. I don't mind patient C, but I have big problems with patient B and patient D. So patient B is the patient that doesn't void. Whatever you do, you've done pain relief, you've done everything, not voiding. It's okay. You say, don't worry. We put a catheter in for 72 hours. We make sure we give them pain relief. We bring them home and start again. If we start again, usually if they're A or C, they go home. If they still don't empty their bladder, that is when you need to sort of have a little bit of wrinkles on your forehead and say, oh, you haven't voided for the second time. Look, we can put a catheter in for another 48 hours, see how things go. Usually there's inflammation and patients will be very accepting. If it is an issue where you think that you've either overcorrected it with anti-repair or a sling, our threshold is less than 1 week. So if the patient's not voiding at all, you can give 2 or 3 goes with 48-hour catheters. But if after that, take the patient, just free the bladder neck with the sling or your anterior repair, and the patient will void, believe me. But don't leave it more than 2 weeks max, because you can't find the stitches or you can't find the sling. Sometimes it's difficult. The most dangerous patient is patient D, because this patient actually says, yes, I'm passing urine, but they are passing very small amount of urine with high post-void residuals. They might as well be like patient B. So beware of the patient that's passing very small amounts of urine, 50 mils, maximum 100 mils, but retaining 200, 250. That patient should also be categorized as patient B. Again, they go through the same protocol that B goes through. So if I have a patient D, I am more worried because they're passing small amounts of urine. They go, no, I'm passing urine. I'm fine. I'm going home. And usually they develop the neurogenic bladder. So it's very important to have this algorithm. Please feel free to copy this algorithm. It's on my website. It's free. Use it because it will help you a lot, and your nursing staff and your junior doctors. So I don't know whether it's time for questions. I am very much on schedule, I think, Dr. Shrikala, or should I take questions at the end of the second talk?
No, sir. I think we will take questions now.
Beautiful.
That was a really wonderful talk on the most important point, which many of the practicing obstetrician and gynecologists have doubt. So thanks a lot for a wonderful talk and giving a very clear, no nonsense slide that, what to follow. I think we can have it stuck in our labor ward and our post-operative ward.
I will share my website. Someone asked me on the chat, what is my website called? It is basically pelvichealth.com.au. Very simple. pelvichealth.com.au, and or just go on Google and Google my name. It will come up straight away. So don't worry. It's all good.
It was an excellent talk, Ajay. So the very important, the beginning message, where we fail to tell the patient what we are going to do. And as the patient gets up and she is with some tubes here and there, then finally we talk to the patient. The message, what you have just gathered is with that vaginal pack or a catheter, we have to talk to the patient and make sure we are going to leave behind, how long we are going to leave behind. That eases out a lot of problem. I think that's a very simple, practical point to the youngsters to carry on.
May I take this opportunity also to do namaste to my guru and good friend, Professor Ajit Vaze. What a fantastic occasion to have him with us. He is one of my closest and best friends and a wonderful colleague and a great mentor. So, Vaze sir, namaste.
Sir, pranam. Thank you very much.
Great man, great man. That's all I will say. I won't say anything more.
He was spontaneously, he agreed to join us. Though I wanted him to talk on another program with us, he agreed to do anything, any talk you give me, I will join. So today,
Srikala, I can tell you only one thing. He loves talking with me. So we are a really good team. If you put us together, you can't control us.
that's true. Now, the many of one question from all the obstetric and gynecologists is,
Yes,
if they have been following this protocol, they would have recognized that the bladder was full and they were not able to pass. But most of the time, they find it when the bladder is distended to around 1500 ml. And then they put a catheter, and many of them are in the habit of doing this bladder drill. And they try and remove the catheter after 48 hours. Again, it is the same scenario that she doesn't pass urine at all, or max of 50 ml. And again, they put in a catheter, bladder drill, and again remove, and they still face the same problem where there has been no sling. I'm just talking of an uneven full bladder, vaginal delivery where there is no hematoma, where there is no pack, an uneven full vaginal hysterectomy where the mother-in-law was respected. In spite of that, they do going for retention. Here, many a times the family comes with the opinion that the obstetrician or gynecologist has damaged the bladder. And so some in this scenario, the problem, the tips and tricks which you have told that we don't go into the scenario, yes, we do. But when they see the patient at this level who came with 1500 ml of residual urine and not passing after repeated trial of void protocols, how do you guide them? How do you counsel them? Is there a role for bladder drill anymore? Do you believe in that? What is your...
That was the easiest question you asked me. So short answer is no. I don't think that clamp and release actually works on the detrusor. That's not true. People have tried to use stuff like bethanechol orally to try and make it work. There is no strong evidence. It's not level A, not level B. I think it's level D evidence that maybe it acts as a placebo in 30% of patients. I think that the bottom line is there is that what we call that comfort time for the bladder. Once you pass that zone, once you have had over distension injury, it really becomes very difficult to get the patient to void. Believe me, once you get that detrusor cell dyssynergia, as we call it, it's really difficult. So if you've got a patient with 1.5 to 2 liters of urine with retention, my suggestion usually is don't do 24/7, don't do 48-72 hours. Probably give it about a week, because you've got a patient who's already had a highly over distended bladder. And don't do clamp and release, just leave it on absolutely continuous drainage. One of the things that I think people speak very freely, but don't really believe in it, is they talk about clean intermittent self-catheterization. So far in my life, I have not met a single woman who actually says, thank you for giving me clean intermittent self-catheterization. They hate it. It's got its own problems, right? Also, as people get older, they get arthritis, they can't use it. People are getting heavier, as in weight-wise. It's very difficult for them to manipulate to put a catheter in. It's very easy to say, do self-catheterization. It's very difficult to actually make a patient do that time in, time out. If you're lucky, in 12 weeks, your distension injury may come good, and you might actually be able to get the patient to pressure void by straining, and also by squatting, and also by raising their legs. That could be one. But you have to scan them maybe year or two yearly to make sure there's no backflow, because otherwise Baba Vaze will be yelling at you, because now you've got hydronephrosis, hydroureter, and then we are in real trouble because you've blown the vesicular reflux, and patients getting recurrent UTIs. And Mutulata is also not going to be happy. She's going to say, now I have to do a nephrostomy, or I have to do a suprapubic catheter permanently. So we need to be very cautious. If the bladder is not working, it should not be something you take lightly, right? And I don't agree with prolonged catheterization, but you might have to keep it between 6 and 12 weeks, because after that, the women go through the other process of prolonged catheterization, which is encrustation, formation of stones, recurrent urinary tract infections. The bladder looks like someone has poured boiling water in it. If you scope it after 6 weeks of a catheter, it's a foreign body reaction that the bladder gets. So we need to really love the bladder. That's what I'm really trying to say. Love it, take care of it. But your sweet spot and comfort zone is the first 8 hours. You have to be super vigilant to make sure that you look after the bladder for within the first 8 hours. I hope that answered your question.
Yes, sir. Dr. Naima Fatima has asked, what are the factors which permanently damage the detrusor? You were talking of that over-distended bladder which damages the detrusor. Any other factors you want them to be aware of?
Well, look, I think the detrusor muscle is just like any other muscle. But I think a couple of things that I would say your red flags, if I may say. One is, of course, neglected retention. But second thing is uncontrolled diabetes, and which is now very common. People don't even know they're diabetic. And you have this bladder that's actually neurogenically damaged because of hyperglycemia. So, and what happens is all you have is this tipping point. Everything is kind of going a little bit like this, and then you do the surgery and it's tipped. You've got the tipping point of the bladder. So I think from a other factors point of view, I think probably the most important is to make sure that the patient's not diabetic. You can talk of multiple sclerosis, Parkinson's, and all sorts of other diseases, which are not really significant factors because the numbers are small. But diabetes, neurogenic, diabetic, detrusoropathy, as I call it, is a very, very unrecognized situation. And just to share my experience, in the last 3 months, I have a research fellow from Sydney, and we decided that every single patient over the age of 50, we're going to do an oral glucose tolerance test. Every single patient over the age of 50. Can you guess how many people were diagnosed diabetic? 30%. 70%. It's a big number. And these people are coming with specific pelvic floor dysfunction. And you are wondering, oh, why is this bladder not emptying? Why is this woman getting recurrent UTIs? Because they're diabetic. You ask them, are you diabetic? They go, no, I'm not diabetic. I had a blood test and my blood is 5.4. But how do you manage a load of glucose? So I think a random blood sugar is useless. We have to look at doing a glucose challenge and how the insulin actually works when you get a glucose load. You'll be surprised how many people are diabetic. So we have a 70% OG. Our endocrinologists are absolutely in shock. Only 3 months we did the study. So I think our diet, everything is an issue. We are metabolically challenged people. Doesn't matter whether we live in India or we live in Australia. Metabolic challenge is very high in the middle class and the upper middle class. And so we need to be very aware of our HbA1c, or even do a GTT yourself and see how you handle sugar. So those are the two important things: overdistension due to pain and neglected retention. And the second one is endocrine metabolic disorder.
Thank you, sir. And now one question to Dr. Muthulata, madam. Madam, you have beautifully talked about the prevention and management of bladder injury. But once a gynecologist or an obstetrician injures a bladder, they feel very guilty and low down, and their morale is really affected. And so how would you counsel them on that aspect? And a word about documentation, because many are even worried to tell the patients that they injured the bladder. Am I audible, madam?
We have to document. Yes, you are audible. See,
Yes,
definitely documentation has to be done. Okay, and we can explain. See, because all the time, you know, this is going to be a thing, and the bladder is adjacent. As Dr. Ajay Rane said, the anatomy, yes, it is very close to that. And when you are going a section, definitely there will be some problem. See, this is, so you always you document. That is very, very essential. And please don't be in a panic when you injure a bladder. Definitely there will not be any problem. As I said, you finish off your primary surgery, then you come to the bladder, and patiently you can, by that time you can buy some time for you to get accommodate for that. Then you can go and suture that thing. There will not be any problem, but documentation is essential. It is mandatory. What, sir? Am I correct? Ajay Rane, sir.
I could not agree more with you. I think the biggest problem is fear. So gynecologists will put a telescope in the abdomen called a laparoscope. They will put a telescope in the uterus called a hysteroscope. But somehow they have this worry that if they use this instrument called cystoscope, it's never going to come back again in their hands. So I think the first thing we need to do is, you are all scopists. Why don't you learn simply to do cystoscopy on every single patient? Do a cystoscopy on every single patient. As a practice, you'll get to learn about the bladder, the detrusor, the ureteric orifices, the urethra. Then when the injury occurs, you know how to fit the cystoscope. If you are going to start learning cystoscopy when you have urotrauma, it's too late. Too late. You cannot understand the value of doing it before. That's number one. Number two, always have a box of mithai, maybe a bottle of whiskey for your friendly urologist. Every Diwali, you have to give it to them. Okay? Because what you don't want, you like that, Dr. Vazit? Because what you don't want is the urologist sometimes, and I'm sure you guys don't do it, but sometimes they go, what have you done this time? That will take the confidence of the gynecologist away. You don't want a urologist who's putting you down, because urotrauma is inevitable. It doesn't matter how much good you are a surgeon. Complex cases, urotrauma is inevitable. So you really don't want the gynecologist to feel even more worse because they have had trauma. Trauma will occur to anybody, even the best of hands. So remember the box of mithai and the bottle of whiskey. Very important. Keep your urologist happy. So it's a multidisciplinary partnership. And I think that is something we tend to forget. So two things only: learn how to do cystoscopy, and two is refer early rather than late.
Sir, another senior gynecologist, Dr. Hemlata, has asked us, since most of us most of the gynecologists don't have a cystoscope, can they use the hysteroscope as a cystoscope?
100%, but take the pressure off the bag. Otherwise, you will explode the bladder. So it has to be gravity filled. You can use a hysteroscope. And it's a 30-degree scope, so you may not get the vision of a 70-degree scope, doesn't matter. Start learning with the 30-degree scope. Take the pressure off though. It has to be gravity fed 120 centimeters. Otherwise, you'll blow the bladder up with the high pressure. But yes, absolutely. I think that we should start encouraging all gynecologists to do cystoscopy, not because we want to become urologists or urogynecologists, because this organ is so close to what we do, you need to have some idea about that organ. It is important. So I think that all the juniors, if they learn cystoscopy, simple cystoscopy, there is a lot of confidence that comes into them when they suspect urotrauma or when they have urotrauma. They can either repair it themselves or they can confidently refer communication to the urologist. I think I have a fundal cystotomy with a 4-centimeter incision. It is 3 centimeters away from the trigone. The urologist is going to say, take a needle holder and take a 2-0 vicryl and close it. End of story. You have done your opinion, you've done your multidisciplinary, you have taken care of the patient. So if you know what you're talking and you communicate it, the patient also is saved a lot of a trauma. And I'll just give you an example. In 1997, we did a survey of colorectal surgeons in the UK. And we asked them, simple question, 4-degree tear during vaginal delivery, would you do a colostomy? 78% of colorectal surgeons, they will say they will do a colostomy. This is very scary. Because,
I have joined on this particular day.
Basically,
designation.
I think it's Professor Gopinath. Sorry, we'll get you muted, sir. Thank you. Can you imagine how many women will be running around with colostomy bags for a 4-degree tear? So we had to explain to the colorectal surgeons that 0% of patients with a 4-degree tear need a colostomy. So I think the multidisciplinary approach is very important. We need to talk to each other. Otherwise, they will do what they know best. A colorectal surgeon says, okay, there is trauma to the rectum. I have to divert. I have to do a colostomy. Of course, that's what they've been taught. So I think that multidisciplinary approach is very important. You know, you cannot expect a urologist to come who maybe doesn't know what a TLH is. And you say, I've got ureteric trauma. He's either going to do a laparotomy or, he's going to have a look. He's going to reimplant the ureter. Maybe a stent could have sufficed. We don't know. So having that constant dialogue between specialties is very important. That I think is important. Don't be scared. And I think that's why that box of mithai is very important. Buy some, whatever you want. Every Diwali, whatever, Eid, just send the present to your friendly urologist and friendly colorectal surgeon. It's good to have different colleagues together. Madam, you need to unmute. Shrikala.
Unmute.
Thanks a lot, Professor. Thanks a lot. It was wonderful. May I request Professor Ajit Vase, our former President, Urological Society of India, to add any few words or comments?
Well, it's always a great pleasure to see you as well as Professor Dr. Ajay Rani. We call him as a humdinger, a magnanimous and a charming personality, not because of his looks, but because of his practical sense, which he goes on imbibing all over the world. Only point which I have to tell you, if the retention remains for more than 6 weeks' time, it is preferable for all the gynecologists to call and talk to the urologist concerned, where if possible, in all the metro cities and Sec 2 tier cities all over India today, urodynamic facility is very easily available. And that can differentiate 2 important things. Number 1 is hypocontractile bladder and acontractile bladder. And what Dr. Professor Ajay Rani said, hypocontractile bladder will come in what is known as a stage C. while a contractile will probably go in stage D and will kill you for years together, because large amount of research which is going on in European urology, and I am also a part of that process for underactive bladder. We have still not understood that entity. And what Dr. Ajay said, it is more common than what you think it to be. It is more common. Many a times the elderly people who come to us with almost a palpable bladder, with a history of diabetes, these people go from years and years together exactly as what it is. Till they land up with either a raised creatinine or a blown off renal failure in a part together. So better to quickly get these people picked up after 6 weeks, it is wise. And the last one is after the sling for first 7 days, as what both Ajay and me, we have done several procedures together. Today, there is a very standardized with level 1B evidence process available where you can open up a wound locally, put a right angle forceps between the sling and the urethra. Of course, the urethra has to be first catheterized, and just gently separate so that you loosen the procedure. And the loosening of the sling on 1 centimeter on either of this side will immediately make a dramatic effect together. So early loosening is a known and accepted phenomena as what Ajay said together. But any gynecologist should not have a dilatation, cinching in your otis urethrotomb or giving a pressure to those slings. That is going to have a more deleterious damage and a permanent damage rather than a cure itself. Thank you, Professor Ajay. Always lovely to speak to you. And SEQUELAE, it's a great...
Thank you, sir. Thank you. Thank you. So now I think we had a wonderful discussion. Now over to you again, Sir Prof, so that we will talk on the global perspective of VVF as well as the much awaited tips and tricks to the practicing gynecologist. Over to you, Prof.
Thank you. Thank you again. I want to share with, this is a, now why is this not moving? Here we go. I want to share with you this vision because I know that everybody wants to do, everybody wants to perform certain procedures. But I think it is also very important to understand how we work globally. So basically, I want to share with you for the first 10 minutes, the global vision, and then some of the impact we have made around the world, and then the tips and tricks, okay? So WHO recently announced that there will be an end to fistulas by 2030. And the first thing we did was, oh my God, why does WHO make statements like this? Because as long as women are pregnant, as long as there is poverty, as long as there is problems with transportation, you will never end fistulas. What would be a more achievable goal? I will tell you as we just go through this little journey, so please bear with me. I'm the past chair, but chair of EAG for the FIGO Fistula Committee. We saw the FIGO supplement of obstetric fistulas of 2007. This year, 13 years later, nothing has changed. Nothing had changed in the way we address fistulas. So we said, should we be asking the hard questions? The hard questions are very simple. We need a uniform FIGO classification that will help all surgeons, just like the cancer classification from FIGO. The FIGO manual, we have now managed to print in 16 languages, a uniform adaptation of the FIGO manual for treatment of fistulas. It divides fistulas into simple, complex, and advanced. So when someone is talking to Professor Vaze, he will understand if they say, Prof, I've got a simple fistula, I've got an advanced fistula, I've got a complex fistula. So we are speaking the same language. The next part is the politics of fistula. You have got USAID, UNFPA, FIGO, IUGA, OGS, Engender, Fistula Foundation, Freedom from Fistula, ISOFs, RCOG, thousands of people trying to do the same thing. Why do you need 1,000 people doing the same thing? Why can't we all come under a neutral roof? It is because of power and ego, nothing else. My foundation is better than your foundation. My country is better than your country. And we are spending billions of dollars because all these different people are trying to do the same thing, but in a different way. The uniform training of local surgeons. African surgeons must operate on African women. Bangladeshi surgeons should operate on Bangladeshi women. Nepali surgeons should operate on Nepali patients because their comfort is so much better. So many times I have done it myself. I call it meditourism, where you are only going to operate, but not teaching. You're not conveying your skills. That is a waste. What are you doing meditourism for? And I'll show you what the devastating effects it does have. The uniform setting of surgical tools. If you are a fistula surgeon, you need certain tools. And I will show you what we have done. The uniform setting of evaluation, just the patient's shaking her head saying, I am fine, doesn't mean you've cured the fistula. Uniform setting of follow-up, research protocols, communication links, it's all, the list is big. So what are the risks of setting a goal like end fistulas by 2030? Number one, everybody is in a hurry. Number two, you're going to take risks because you have to achieve this. Number three, you will fudge the data. Number four, you will be cornered to achieve that goal on paper. So sometimes you can be a bit irresponsible when you make statements like end fistula by 2030. What are the advantages of having a goal? Well, maybe we'll have more sustained resourcing. People will give more money. There'll be more standardized approach and more attention to the issue. I don't think that's happened. Fistula in the world is not sexy surgery. It is not like laparoscopic surgery. Unfortunately, it happens to very poor women. So very few people want to do it globally. Even the surgeons we train, we have a 25% attrition rate because they get skilled, they go into doing private practice. They don't want to look after fistula patients. Is it really possible as long as women birth that fistulas will end by 2030? Would it be better that we say that no woman should wait more than 6 to 12 weeks to get a fistula fixed? Really achievable goal. So this is what we have been working on with FIGO. And I have to tell you, I shouldn't be telling you about our success, but I'm going to share it. So some years back, the term fistula tourism was coined. A lot of surgeons, unfortunately, from my part of the world, the Western world, used to come to Africa and perform surgeries. And we have seen 100% failure rate at times, 100%. They've operated on 149 women in Uganda. All women failed fistula. And those who are fistula surgeons will know, first attempt is the best attempt. And so we are very against fistula tourism. We don't want these surgeons. We want their money, but we don't want the surgeons. Because these people have no fistulas in their countries. How can they suddenly become expert fistula surgeons? So this was one of the biggest problems. We have heard of camps where visiting surgeons have come at great expense, promoting their good work back in their own country, only to leave every woman they operate on still leaking and leaving the patients and the staff dismayed. And because they come from a poor country, they don't have the guts to speak up. So we have definitely trying to change this. Who is this reportable to? How can this be monitored and curtailed? Ego is taking a big role in this. The other problem we have found now is that we are very good with the first V of the vesicovaginal fistula, closing the vesical part, but not very good with the vaginal part, especially with this vaginal loss of tissue. So we are finding that even though you close the fistula very well, 50% of the patients are still wet because you have tightened the vagina so much the urethra has become incompetent and they just keep leaking. The patient wants to be dry. She doesn't care whether it's dry from the fistula or dry from the incompetent urethra. So these are the tough questions we need to constantly ask. Our other problem now, recently in Africa, we did our biggest survey, and until 2015, 98% of our fistulas were vesicovaginal obstetric fistulas. Now, 45%, 44.5% fistulas are iatrogenic from cesareans. So now we're seeing a much more complicated fistula like juxtacervical fistula, ureterovaginal fistula, ureterocervical fistula, not the standard vesicovaginal fistula used to happen. So all the surgeons we trained in vesicovaginal fistulas now are finding it very difficult because the emphasis now has to change to performing safe cesarean sections. They are giving their own spinal or giving ketamine. Poor woman has come through obstructed labor. They are doing their best. I'm not saying they're not, but we're seeing much more iatrogenic fistulas. And the problem is they can't be dealt with by the fistula surgeons we have trained for vesicovaginal fistula. It requires ureteric reimplantation, etc. So it's a harder job. We have trained more than 106 surgeons. Our goal was 100 by 2022. We have trained 106 surgeons already. We believe that by 2030, if we go by the rate we are going, no woman will wait for more than 6 weeks to have her obstetric fistula in the world. Currently, there are, we believe, around 900,000 women who are waiting to have their fistula fixed. It was 1.2 million. And now with COVID, I think we'll have gone back to 1.2 million, sadly. You have seen this wonderful picture. This is thanks to Professor Raji and all the wonderful people from Gosha Hospital who have supported us. I am so happy, Srikala, that you don't get a lot of fistulas anymore. I know you get some, but not a lot. This is what it was supposed to be. You have a fistula ward, you have dedicated it, you have managed it very well. I love coming to you. I will be there in June, don't worry. But the idea was we wanted to ensure that the load of fistulas comes down a lot through proper obstetric care. And I think the small amounts, you've got very, very talented people like Professor Mutulata, Srikala, who can manage it reasonably well. So just wanted to show the first picture. This is Dr. Chitra. I hope you remember this. Look, we have a lot of heroes. We have Mohan in Nepal. We have, of course, the great, wonderful Saiba Akhtar from Bangladesh. Great people looking after fantastic fistula training programs. Perhaps the most important person is Catherine Hamlin, who passed away, and that her hospital in Addis Ababa was the one that really led the way to teach us how to teach local surgeons. So this is what we do. We have 5 training centers. We do on-site training of all the surgeons. We actually have 200 surgical trays with ureteric catheters and everything that we have provided free to these hospitals so that they have the standardized equipment, good scissors, good retractors, good surgical tools. Now we are even going more with this. Fistulas go through all women, whether you're a Muslim, whether you're a Hindu, whether you're Christian, whether you're African, whether you're Bangladeshi, whether you're Nepali, whether you're European, it doesn't matter. It transcends all races, religions, ages. Here's a group of our young fistula patients in Nigeria. You have fistula patients in Tanzania. All of them just waiting with a horrendous lifestyle. It's a very, very bad way of living, especially if you have double fistula. So very truly, my friend Saiba said, the lucky ones die and the unlucky ones get a fistula. She couldn't be more right. It's a curse, and we want to remove this curse. So just in the last 1 minute, we have local heroes, mostly in Africa is the problem. They are amazing people. We've trained more than 100 African surgeons. They're looking after their own patients. Their skills have become so good, Professor Vaze, that I am learning from them now, because that's what they're doing. How many fistulas did you do this year? 600. You know, their numbers are incredible. And so I think that there's a lot we can learn from them. I go and just talk to the patients, because I love talking to the patients while these guys are doing fantastic surgery. So we had our first communique, which was the first 6,000 fistulas we did through our training program. This was 3 years ago. Now we have crossed 12,000 patients. So we are exponentially increasing. Our success rate is around 84.5%. So we are taking care of both V's, vaginal V, vesical V, and it is all done by local surgeons on local people. So there is a pre-op care, there is intra-op care, there is post-op care. And so it's a wonderful feeling we have that we think we are making a difference to the world by training these surgeons. And the expert advisory group is responsible for it, not me, not Andrew Browning, not Saiba Akhtar individually, but together we make this work. So it was very strange that the French president said, how come there are 2 Australian doctors who don't come from Australian cities, but come from Australian villages, who are making the biggest difference in the world? And it does not matter where you come from, it's whether you have the heart to make the change or not. So I pay my respect to Dr. Andrew Browning, who comes from a very small place near Sydney called Gosford. And with him and me, currently we are running the program. Andrew has actually fought COVID, gone to Africa. He's staying there. He'll come back. He will quarantine. Such is his dedication. And I will follow in March. I will go to Congo in March. But it is something that we believe we will make a big difference to women's lives in the future. So what are our lessons learned? Let's do the global lessons and then we'll do the tips. Fistulas can be possibly eradicated by using both ends of the equation, prevention and treatment. There are 3 Ds: delay in diagnosis, delay in transport, delay in treatment. You want to bring all those 3's down. It is a team effort. There is an excellent manual. I was doing a webinar in India. A lady said, how do I get the manual? I said, you are FIGO. FIGO is 132 countries. She wrote to FIGO, within 24 hours, she got a PDF version of the manual. So if you want the manual, just contact FIGO. You are FIGO, we are FIGO. Who is FIGO? FIGO is not this imaginary body, it's us. So if you want the manual, you can just email them and they will send you the PDF. It is absolutely happened within 24 hours. There is excellent backup by the FIGO staff. Anyway, my take-home messages for you for fistula. I think, so last Monday in a wonderful, I don't know whether it's 2-tier or 3-tier, but Dr. Vaze will tell us, city of Nasik. It might be 3-tier, Nashik. I did a rectovaginal fistula by Zoom. I helped a colleague, a complex rectovaginal fistula. It was brilliant. It was how we should help people. And I just feel that one of the biggest problems we have is we are seeing more posterior fistulas, rectovaginal, anovaginal, than vesicovaginal in Australia, and also I think to some degree in India. And that is because we are missing buttonholes, we are missing sphincter damage. So the first thing I would say was, please learn to do a PR after every delivery. I know Professor Vaze says my messages are simple, but I would just like you to understand that there is a power behind simplicity, and I thank him for his very kind words. There is a power behind simplicity. A simple thing like a PR examination takes 5 seconds. After every delivery, please do a PR. Learn to do a proper laparotomy and cesarean section and reflection of the bladder flap. I think don't worry about the amount of time it's going to take. I do my Caesar in 7 minutes. Who cares? Can you do a proper laparotomy? And this has to start with our basic surgical training. I remember, and Srikala will agree, and Mutulata will agree, that we did 6 months of surgery during our 3 years of OBGYN. Why? People understood the importance of learning proper laparotomy, proper suture handling, basic surgical skills. We're going back to that. I was just talking to someone in Hyderabad, and they were the DNB students. I was teaching them knotting and telling them, take the knot to the tissue, not the tissue to the knot. And even on models, the models were being torn off because they are pulling the stitch while they're putting the knot. We have to learn, go back to our basics, learn proper laparotomy, learn a proper cesarean section, reflection of the bladder flap. This whole desire to do very small transverse incisions to do a Caesar. If you increased it by 1.5 centimeters, that woman is not going to wear a 2-piece bikini. Please don't try and be clever, because you need space, especially if it's a fully dilated Caesar. So understand what type of operation are you doing. In case of doubt, we've already discussed this. Seek help and drain the bladder. You have to drain. The bladder is very friendly. It's one of the friendliest organs on the planet, but only if you take care of it. If you have any problems of a fistula, evaluate with dye. X-ray or CT, doesn't matter. It depends on where you might be, but CT, urogram, life-saving now. Please don't experiment. Refer if need be. Don't experiment that, oh, I can look at the video on YouTube and I can fix it. Don't experiment. Remember, this is a woman at the end of your knife. The first chance for fistula is the best chance. After that, doesn't matter, even professors sitting here, Vaze or Mutulata are operating, the success rate goes exponentially down per repair because there's too much fibrosis, etc., etc. So don't experiment. And the principles of repair are pretty simple now. First, there is some controversy, but I would say there is no need to wait for 12 weeks like we used to. We used to wait, let them leak, let it become really small. You don't need to wait that long anymore. Unless, of course, there is infection and there is granulation tissue. Then you need to wait for maybe 6 weeks. Freshen the edges, protect the ureters, do a tension-free horizontal repair for both bladder and bowel, cover the tissue with something, fat, muscle, flap, whatever you can get, cover it. Put something in the middle. You have to ensure a tension-free vaginal closure. This is the hardest bit. But sometimes you think, I can close the vagina. You put your hand there and you put your foot on and you try and tie the knots. But the vagina becomes very rigid and it opens the urethra, the posterior part. So you have an incompetent urethra and the patient will leak. There are some very dramatic things that we do called the Singapore flap, but that is when you have massive tissue loss. You have a 5 centimeter fistula. You don't need to do that. Unfortunately, I hope you never see fistulas like that, because that's something you will only see in Africa, I think. And even there, they're becoming less. As we had a previous speaker say, drain the bladder for 10 to 14 days, but learn to understand the value of a cystogram. I think just taking the catheter out is no good. You can do a simple cystogram. And if you've got a leak, you might want to wait for a week or two. If you haven't got a leak, you might want to take the catheter out. So these are simple things, but I think the issue is we try to overthink everything. In fact, I would say, like Gautam Buddha, just hold your fingers like this and one knot at a time, unravel one problem at a time. And then I will just carry on. So with that, I'm going to stop my lecture because my doorbell has rung, but I'm going to answer it and then come back to you.
Thank you. Thanks a lot, sir. That was excellent. Shall we go on to the next or wait for him to join?
SEQUELAE, you can go on.
Yes, sir. Yes, sir. So I will go to the next topic is mine. In case sir joins, we will call.
I am back. I am back.
Yes,
Yes,
sir.
it was only the front door. I think someone was telling me it's time for you to go, but I will stay for a few questions.
Yes, sir. Thanks a lot. It was a really, really wonderful talk. We had a global view and also the tips and tricks. Though the number of slides was very less, it was extremely useful and highly catered to our audience. Our director wanted to talk a few words, sir. May I request Professor Kalaivani? I think you need to
I will go mute. You need to go unmute, Doctor.
Thank you, sir, for that wonderful lecture. We had all the practical points dealt with. As an obstetrician, it was very useful for us. And again, as you said you will be coming in June. Hoping to see you in June for the urogynecology procedures. And the Society of Vaginal Surgeons, mostly the vaginal surgery as postgraduates, they are more interested on laparoscopy and the art of vaginal surgery. And once when they face all these problems, and now they have an idea that they can deal with it very efficiently, sir. Thank you, sir.
Thank you. The young people always like to pick up what's sexy. Yes. And I think that laparoscopic surgery is sexy. There is no question at all. There's lots of shiny tools. There's lots of television. There's lots of good vision. One of the problems we have with vaginal surgery is we haven't managed to make it sexy. And we can do that. And how do we do that? So I remember, whenever there is vaginal surgery, the residents put their neck down because they know they're going to have a sore back because they're going to bend and they're going to hold lots of instruments and the consultant is going to shout at them and nobody's going to be happy. You can use a very clever device called an exoscope using your same laparoscope, same camera. It's a stand that holds the laparoscope vaginally, and you do all your vaginal surgery looking at a TV. Assistant is looking at TV. Surgeon is looking at TV. Nobody is bending their back. Nobody is hurting. The vision is very clear, and you can teach, because otherwise it's a small hole and you're trying to explain this is the uterine artery, this is where the uterus is going, this is the uterosacral, and they can't see. So the young people, when they can't see, nowadays all mobile phones, everything is, they have to see. So as teachers, it is our responsibility to change. We have to change. We have the tools now. We can just use them in a better way to make it more interesting for them. And I think that is the reason why I think there will be a resurgence of vaginal surgery. Because when I come to Gosha, we are going to, everything will be on TV. You can't hide. If you say that is the uterine vessel, the camera is pointing out to it. If you call the ureter the uterine vessels, then you can bear the consequences of it. So I think the bottom line is, for our junior doctors, we have to make it more interesting, more challenging, more understanding, so that they can do both laparoscopic surgery and vaginal surgery. So my plea to, of course, the great professors from Odisha is, let us make vaginal surgery more sexy. Let's make it like laparoscopic surgery, so that, and it's not very difficult. It's really a question of audiovisual. And then the Society of Vaginal Surgeons will flourish enormously. Again, it's all basics. What is the junior doctor thinking? Because they don't want to have a bad back. They don't want to have neck ache because they're holding on like this to an instrument. And we can get rid of that very easily. So we use something called an exoscope. I can do a little lecture on that sometime, SEQUELAE, if you want me to, on how everything we do now vaginally is watched on TV. Everybody watches on TV, just like laparoscopic surgery. Everything is done on TV. That makes it so much more easier for everybody to see, to learn, and then you don't have that dark hole when they're look, what, looking, what, who knows? But you know, is that look, that'll all go away because you can see it on the screen. So it is my plea to the Society of Vaginal Surgeons to make this surgery more sexy. More, and I know it's a probably not a word that people want to hear, but that's what laparoscopy is all about. Robotics is all about the same thing. There is a lot of hype value to it, you know. So when they say we are going to only give you 3 incisions to do your hysterectomy, I say I'm giving you no incisions.
Yes.
Yeah. Thank you.
Patient don't see the incision. I think it will
Dr.
change
Ajay?
the mindset of the youngsters, because in vaginal surgery, sometimes we tell them you just retract, don't see inside. Maybe once when we give a global view of seeing everything, they will be more mesmerized. Thank you, sir.
Dr. Ajay, probably in the next month, in January 3rd week, in one of our meetings, you can show how it works and how it attracts people.
Yes, sir.
Absolutely do that. We do 2 things: use of exoscope and something called VENOUS. We can do a half-hour talk on that with videos.
Half an hour, we can do that on 20th of January.
No problem.
SEQUELAE, please note down.
Yes, sir. I will coordinate.
Yes, sir. Great.
I'm always happy to do that because education is in my blood. I just get the greatest pleasure to mentor and educate. I don't get any more pleasure in doing. I really get more pleasure in handing over the doing, supervising the doing, getting good results with others doing. And I think that is the evolution of, I think, teachers, I hope.
Great, great. God
Thank
will
you.
bless you abundantly.
He has already. Thank you so much. I am going to take leave because the other party in Dubai wants me to talk. So thank you so much.
Thank you. Welcome. Yes, SEQUELAE, we can move on.
Yes, sir. I will do the share screen now and we will start.
I don't think SEQUELAE needs an introduction. And I have been watching her right from undergraduate days in Kilpatrick Medical College. And later on, she did a gynae, and then she switched over to Euro, and then come back as a Euro gynae. And probably I think we are a great friends for more than 2.5 decades. So it's a great privilege and honor, and she's very sincere, very down to earth, and you give her a job and you can just take it for granted, it will be done. That's a kind of a sincerity I see in SEQUELAE, and she's always friendly and ever smiling. And over to you, SEQUELAE.
Thank you, sir. Thanks for the nice words of introduction. We owe it to all great teachers and mentors like you, Dr. Madhavi, Dr. Kalavati. The list goes on. We are all from a background of not a doctor, so we owe it entirely to you. Thanks a lot, sir. Respected teachers, senior members, my dear friends, and my most beloved postgraduates, the talk today is a vaginal VVF repair. I know once we get a VVF, it puts both the doctor as well as the patient and the family into a great difficult zone. We know that fistula is defined as an epithelialized communication between the bladder and the vagina. Just a small theory, we know the most common causes of VVF are obstetric injuries, which are now becoming less, operative injuries, mostly hysterectomy, genital tract malignancy, and radiation therapy. Though Muthulata madam was telling, the incidence is the least with vaginal surgeries, which we can be proud of, and it increases to laparoscopy and in hysterectomy. In obstetric, we know that it can be a prolonged obstructed labor, ischemic necrosis, or instrumental delivery or injury during a cesarean section. In gynecology, hysterectomy is the most important cause. The fistula develops secondary to an unintentional inclusion of the thickness of the bladder wall during closure of the vaginal cuff. And there is a localized ischemia of the bladder by inadvertent dissection into the bladder or thermal injury that is most commonly seen nowadays in laparoscopy. There were creating thin and ischemic areas of the bladder which are prone to subsequent breakdown. And we also see cuff abscess as an injury. And the other thing common is pelvic malignancy, especially the advanced CA cervix and radiotherapy to CA cervix. Clinical features, we all know a continuous 24/7 urinary leak is a common presenting feature. There is no normal voiding in between. This differentiates it from a ureterovaginal fistula, where in addition to a normal continuous 24/7 leak, because of one kidney, the ureter and the bladder is normal, patient may be able to void normally in between. The exceptions are a small fistula in the dome or a small pinpoint fistula. They may cause intermittent wetness, which is positional in nature. And the timing, if you take, if it's a recent delivery, an obstructed labor delivery, or a surgery like a cesarean or any hysterectomy, it's around 10 days. It can be very between 7 to 14 days. And if you take pelvic malignancy, we see it in the advanced stage. And in radiotherapy, this can happen years later, even we say decades later, they can happen. And clinical examination, most often, we know the complete general examination, physical examination, etc. The most common diagnostic component is a typical ammoniacal odor, where ammoniacal dermatitis, wetting of the undergarments and clothes, etc. And as part of the examination, the methylene blue and the 3 swab test. Cystoscopy is a very important part of the evaluation. One, we want to assess that ureteric patency, because around 12% we know that a concomitant ureteric injury can also be there. And we also want to look for any suture placement in the bladder or urethra. And as you put in the scope, we want to know the size, the number, where exactly the fistula is, and to see its relation to the ureteric orifices. And we also need to identify and remove any stones or sutures. We had one case of a VVF obstructed fistula which happened 30 years back. She came with a large potato-sized stone in the bladder. And I was talking about fistula as a result of pelvic malignancy or radiotherapy. In that, we need to assess the bladder mucosa. And if it looks suspicious, we have to biopsy it so that we know whether it is a recurrence or not. And as part of our examination, it can be done under anesthesia with the speculum or cystoscopy also, where we need to do an assessment, both visual and manual assessment of the inflammation. We need to know how it is, whether there is inflammation, infection, or induration. So what we generally teach the postgraduates is there are a lot of vowels. You remember I's and E's, whether there is inflammation, infection, induration, edema, etc. So when we talk about the timing of repair, we normally say 3 months. But nowadays, when we try to reduce the waiting period, we want to see if none of these vowels are there. Inflammation, infection, edema, induration. We want to see whether it's a pliable tissue. And you need to assess the vaginal anatomy, including the depth. Because as you see and evaluate these patients, we want to know whether we can do it vaginally or abdominally. Supposing it's a previous 2 cesarean or a previous 3 cesarean where there's a very narrow vagina, the access is difficult. So, but even if a supratrigonal fistula, if there's some associated prolapse, we can easily tackle it from below. If there is an atrophy of the vagina, a pre-treatment with estrogen creams will be helpful. We want to assess the introital size as well as the capacity of the vagina. I told you we need to assess the vagina, the integrity, and whether it is accessible from vagina, how high it is. Supposing it is little high above, how do we still want to do it vaginally? How do we do it? How can we access it? Can we increase the vaginal size and depth by putting a bilateral episiotomy or what we call a Shusha incision? Or, we can even put the patient on a prone position or Kraske approach or a jackknife approach. So all these, while we are examining, we need to evaluate the patient and see how we are going to operate. Also look for any mass or other pathology. Look for scars in the perineum, lower abdomen and thighs. Multiple scars in the abdomen has undergone multiple surgeries. We know the vagina is a better route. And when we were talking of obstructed labor, also beware, look for any rectovaginal fistula associated, which we must not miss. Dr. Ajay Rane was saying, put a finger after examination. So this is very, very important. And then methylene blue dye test is very simple, that we fill the bladder with the dilute solution of methylene blue and put in 3 swabs. What we want to know is the swab soaked? If the swab is soaked and not stained, that means it is wet and it is not colored, we know it is coming from the ureter. It is a ureterovaginal fistula. If it is soaked and stained, then we know it is a vesicovaginal fistula. But supposing the swab which is outermost, that is close to the urethral orifice, it could be a ureterovaginal fistula, or there could be some amount of a stress urinary incontinence. The other thing is, if you have given them oral phenazopyridine, that is a pyridine tablets about 6 to 8 hours, and then filled with methylene blue, if it is stained blue, it is a vesicovaginal fistula. If it is stained orange, we know it is a ureterovaginal fistula. And nowadays, IVU has replaced almost with the CT-KUB. I told you that we want to rule out a concomitant ureteric injury. Here you can see how nicely the cystogram is showing the fistulous tract. Again, the section showing a nice track. This is a cystoscopic view. So after having seen a fistula, what are we going to do? Everybody likes to have a non-invasive approach. A continuous bladder drainage will be helpful in only a very small fistula, say 3 mm. So there is no harm. We can put them on a continuous bladder drainage and try. But supposing it is a fistula, small fistula, we will know that the leak starts coming down and almost stopping. Then we can continue the continuous bladder drainage for at least 3 weeks. But after putting a catheter, it is going on leaking continuously. This will not help, and surgery would be the gold standard. Endoscopic fulguration also can be done in small fistula. So what are the principles? Adequate nutrition, elimination of infection, excellent exposure with watertight, tension-free closure using multiple non-overlapping suture lanes, and unobstructed urinary tract drainage or removal or bypass of any distal urinary tract obstruction, and beware of malignant etiology. As it is a patient who has had a VVF because of a malignancy or radiotherapy, it is very difficult to operate and make them all right. And if you miss a recurrence, then we are in for real trouble. So timing of repair is, Rani sir had emphasized this point. We really need to individualize. We need to know that the first attempt is the best attempt. We need to clear all the infection and tissues to be locally fit. I was talking about all the vowels, edema, induration, infection, inflammation, all that must be gone. If the VVF is as a result of obstructed labor, there is definite ischemia. So I think it's better to leave them for 3 months. But if this fistula has occurred as a result of a gynec injury, maybe we can do it little earlier. And again, locally, you should assess. The scar is on the abdomen. Maybe we can do a transvaginal repair little earlier, provided it is locally fit. VVF as a result of malignancy or radiation, really, one of the chat question was, which you think is very dangerous? Yes, if a patient has got a VVF post malignancy or radiation, it is a real nightmare to make them all right. So you need to delay at least a year. And preoperative preparation with antibiotics, estrogens, etc. Technique of repair, we have different repairs like vaginal, abdominal, putting a glue, laparoscopy, etc. So our aim is to always do the surgery from below. As vaginal surgeons, we are all proud that we can operate doing it vaginally. So as a bottom line, we would like to do every case vaginally. So that's why I wrote what are the indications for the abdominal approach. If the fistula is too high in the bladder to be reached, that is trigonal versus supratrigonal. The teaching is trigonal, easily done vaginal. Supratrigonal, maybe there is a role for an abdominal approach. But many of the supratrigonal fistulas, there is some amount of a sister seal. We will be able to access it from below. And if the vagina is inaccessible, I was talking about multiple Shushat incision and the prone position, etc. And patient's preference is one point. And surgeon's preference also. If the surgeon, what he knows best should be done. If the surgeon knows to do it abdominally only, I think he can go and do it abdominally, or he can refer. And supposing there is previous multiple failed attempts or failed invasive attempts also is an indication. Most important thing is necessity for other concurrent transabdominal procedures, like, for example, as you saw the fistula, it is very close to the ureteric orifice. You feel that while you separate the flaps and suture, you will include the ureter. They are indications for a ureteric reimplantation. And however, the fistula is of a long duration, usually it doesn't become like a thimble bladder. So we are able to do a repair. But in the patients where the bladder has become very small, where it needs an augmentation cystoplasty, or in patients where we need a repair of bowel fistula, etc., an abdominal repair is very good. Vaginal approach. To this audience, I don't need to tell these reasons for the merits of the vaginal approach. So there is one, whether you need to excise the fistulous tract or not excise. Excision of the tract provides clean and vascular edges. Raz et al. Has demonstrated excellent results without excising the fistulous tract without any adverse effect. So if you have enough place for excising, you can excise. But excising the fistula enlarges the tract and it may cause iatrogenic bleeding, requiring hemostatic measures that may inhibit feeling. And another thing, supposing it is a little closer to the ureteric orifice and I excise and it comes closer to the ureteric orifice, again, I'm worried. So now we will show a small video of the vaginal VVF repair. This patient had an obstetric VVF. So this is a cystoscopy. I'm just entering the bladder. Now you can see as Good. Just this is the bladder neck, and they're very close to the bladder neck. In the region of the trigone, you are able to see the fistula. Can you see the fistula? Now, even I come back and now go. See, this is closer to the bladder neck. And now I'm going inside. I will be seeing the right ureteric orifice as well as the left ureteric orifice. And then I will look into the bladder, rest of the bladder. I told you how to see whether it is normal. And now I want to stent the ureter. It is, you know, in the small triangular area of the trigone is the fistula. So I don't want any problem. So I've stented the right ureter now. Can you see the markings? It is. Now this has come to 25 centimeter, 26. And now I take off the guide wire and you can see the stent curling nicely, showing that it is nicely seated. And you can use the same thing and go to the other side and put a stent on the left side. See, you can even put a ureteric catheter, which you can remove at the end of the procedure. But this is a safe procedure. Sometimes if you don't have people to take care, the catheter slips off, you have to be worried. So I put a stent on both the sides and the fistula is in the trigone closer to the bladder. Now you can see nicely both the ureteric stents have curled and they are well placed. And now, can you see the fistula, how close it is from the urethra? We have taken nicely stay stitch. You can put a Foley through the fistula and, you know, a small 8 or a 10 French fistula and distend the balloon and even use it as a traction. Or you can take a stay stitch on the vagina and bring it in front. If the orifice is, the fistulous opening is small, that it is not admitting the catheter, you can even dilate it. But the only thing is you must not enter into a wrong false passage. So the initial aspect is now the infant feeding tube is around. I am doing a hydrodissection. You can use a normal saline. You can use normal saline mixed with adrenaline. I have used this sterile normal saline as hydrodissection all around the fistulous opening. The infant feeding tube is inside the fistulous opening. You can see how close it is to the meatus. Now you make a circumscribed incision around this fistula. So I have hydrodissected. I have made a circumscribed incision around the fistula. So then now you catch the alley. Like we separate the vaginal wall from the bladder in normal cystocele, I am separating the vaginal wall from the underlying bladder and the periurethral tissues. Can you see? All around, I'm catching it with the alley. The infant feeding tube is still inside and I'm trying to clear it as much as possible. If it was low down, I would even create little more distance. But now if I take it little more, I will be very close to the urethra. So I don't want to damage the bladder neck. So as much safe distance as possible, I have separated the vagina from the underlying bladder. Can you see? Like we do in the normal cystocele repair or pelvic organ prolapse, we are routinely, we separate the bladder from the vaginal wall. The same way, we have separated the fistula, that is the vagina, from the bladder. Can you see? All around 360 degrees, I have separated the bladder nicely. Can you see? So now I have enough place to suture the bladder as well as close the fistula. Here I have decided not to excise the fistula because it's very close to the bladder neck and I don't want any compromise. So I've started suturing the fistulous tract. I use 30 Vicryl. So here I'm going to do a repair of the bladder in 2 layers. Only thing, each step you must take careful that you include the two flaps. No, this is what I'm doing, the first layer repair. Can you see how carefully I'm taking the bite on the upper flap, then again on the lower flap? This, can you see? So carefully, I'm taking the from the upper flap and from the lower flap. So thereby I'm trying to close the epithelialized edges of the fistula tract and a few of the surrounding bladder. Okay, so every single step which we take, I see that I take the edges of the fistula tract and a few of the surrounding bladder. Okay, so carefully each step. So I placed that infant feeding tube in one in the middle through the fistula. So here, before taking that, I'm taking another bite from this side, so that, you know, once I take the infant feeding tube and tighten, I may miss out. So before I tighten itself, I'm taking a bite so that it's completely. I'm going to achieve a watertight closure. So that is one of our requirement. I have the following the steps of the procedure. I have hydrodissected. I have nicely separated the vagina from the underlying bladder. I have closed the epithelialized edges of the fistular tract and the surrounding bladder. Can you see nicely I have taken? Now, before I tie, I will take out that infant feeding tube. Can you see I've taken the infant feeding tube? You can see it coming. And then when I tighten, it will be closed completely. So I have covered or not. I'm going to take the infant feeding tube. Okay. We must make efforts that we don't leave any portion. We must completely cover. A watertight closure of the fistula is the most important thing. Okay. Now, can you see? I have completely taken it on sides. I'm going to close. And now I will really achieve watertight closure. Now, the second layer, again, now I'm going to take it transversely only, horizontally. You can take, now when you're planning opposing sutures, we can even do a vertical closure. But again, because it is on the bladder neck, just close to the bladder neck, I didn't want contraction of the bladder neck, causing bladder neck stenosis. So the second layer, I'm also doing it only horizontally. Can you see? I take a bite above and below, whereby I incorporate the perivesical fascia and take a bite on the deeper muscular bladder wall also. I did try seeing, like Rajay Rani sir was saying, I tried putting a telescope and I wanted to see if I'm able to get a good vision, but I was not able to get it. So we went back again to record like this. Maybe next time we will try and follow what he says. So the second layer is something like what we do Lemberts. We bury the previous suture, taking bites on the perivesical fascia and a deeper bladder wall, forming a support. And now here, this was an obstetric fistula. There was no cause for me to do a interpositional graft. So I did not do. Otherwise, I will show you how we take a labial pad of fat and put it in between the second layer and the vaginal wall closure. Now, after this, we need to check whether our it's watertight. So I put in methylene blue. You can put it through the syringe, or you can do it by gravity fill. Take a 50 ml syringe and hold it by gravity and see whether it comes. I've instilled adequate amount of methylene blue, and then I'm going to check for leakage. We are not able to see any leakage, and hence I start the bladder wall closure, vaginal wall closure. Supposing I had taken an interpositional graft, I would have put it that between my second layer of bladder as well as the vagina. So after I close this, it is done. As compared to an abdominal repair, many times when we do an abdominal repair, the patient is with an SPC, with the drain, they have enough drain. So we know that a vaginal repair is very, very comfortable to the patient. So the vaginal repair, we do it meticulously, but it is like almost like a normal vaginal wall closure like we do for the routine patients. And after this, we can keep a pack, which we can remove it the next day. One of the most important aspects of VVF repair monitoring is to ensure, here again, if we want, we can put an SPC through the urethra. We call it Lowesley technique. We put in something like a clamp through the urethra, tent it up suprapubically and make a knife, and then put a SPC also, which will act as a double protecting policy so that it doesn't get blocked, because now we have only one catheter. So an SPC may be useful. Now that I have only one catheter, I always instruct not only the doctors and the nurses, but also the patient to that at least 50 ml of urine must be draining. They should, at no point of time, it should be that it goes in for a, next slide. Don't stop. There should be no, I'll go to the next slide. It should be draining completely, because small clots in the catheter can block and cause clot retention. So we specifically emphasize and teach on them about the follow-up. The interpositional flaps or grafts, I was talking that we do this Marcius pad of fat, which increase the success by enhancing granulation tissue formation, increasing neovascularity to the area, obliterating the dead space, and they provide a barrier line between the bladder suture and vaginal suture. What are the indication? Prior irradiation, prior failed surgery, poor tissue quality, or large fistulas. This is a picture of the Marcius fat pad, and this is one patient where we harvested the labial pad, and it is disconnected at the upper end and then tunneled through to the vagina and sutured. And post-operative care, uninterrupted bladder drainage must be taught to the entire team. And it's nice to include the patient's attenders also in the follow-up, because they really take care and tell us if it doesn't come and the no retention occurs, and avoidance of traction, no tampons, no sex, antibiotics, minimal valsalva measures are all normal. Early post-operative complications like bleeding, spasm, infection. Delayed can be vaginal shortening, stenosis, unrecognized ureteric injury. But most important, we have to talk to them about recurrence also. But this will complete the slide.
Thank you, Srikala.
If there are
It
any
was-
questions, we
it
can
was-
answer.
It's a VVF. It's a huge topic, but you have made it very short and very sweet and very crisp. And people, hello, can you hear me?
Yes, sir. Yes, sir.
Yeah, it's a very big topic. The VVF. It's a very big topic. We have made it very short, crisp, and sweet, and give all the salient points which they have to just follow it up. And you made it so simple that everybody is going to start doing a vaginal approach hereafter. Any comments, Mutulata?
I'm not able to
Nice
hear.
presentation, sir. I know about Srikala, so nice presentation, Srikala.
Dr. Ajit, sir?
Yeah. So it's an excellent presentation.
Are you able to hear me, sir?
Yes,
Yeah,
sir.
we can hear you. We can hear you.
Yeah. See, I do a large amount of fistulas on an average about 1,400 fistulas up till now. But there are certain important adjuncts which are necessary, and now it is available in India. The first is a Scott's retractor. And I will show you, if you have given a choice, we show you a small clip. The second one is all the illumination. The problem of transvaginal surgery is illumination, because the vision is incorrect and the light does not go. So we have what is known as a classical way of Schmidt's suction tube, where the light and suction combination, which is from Storch company, which is commercially available. For last 25 years, I have been using that and has become enormously successful. The third important thing is I put a Foley's catheter, and when I called Professor Shlomo Raz, and I'm sure many of the people who came to Mumbai, and thereafter he came in 2019, 2011, and then 2013 in All India Gynec and Obstetric conferences, he uses a 8, 10, 12, and 14 French Foley catheter, which gives you a good traction so that it gives away. The important part is that there is a classical natural barrier which is present posteriorly, namely the peritoneal flap, and that can be very comfortably and judiciously used for a small fistula. I agree with Professor Srikala that if the fistula is large, we do all transvaginal up to 5 to 6 centimeter. And I have videos where Srikala calls me, I'll show you all the videos. But what is essential, that peritoneal flap can be very comfortably taken. There are certain fixed principles where an anterior flap and a posterior flap can be taken when you are taking a circumcoronal incision on the fistula. And depending on where the fistula is, if the fistula is high, then you keep a large anterior flap so that it has a layers of sutures which are not overlapping, which again forms the principles of fistula surgery. And lastly, but not the least, is we do occasionally, if a large fistula more than 5 centimeter, I do what is known as a bilateral Martius flap, or sometimes a gracilis sling, which can come in, and that gives you a very good support to the part together. Very essential part for all of us to discuss and describe is a post-operative sexual function in these women. They are young people. They have a large active life ahead of it. And as what Professor Srikala told, vaginal shortening is a great problem. But if you judiciously use the anterior and a posterior flap, you can really mitigate this issue of reducing or giving rise to vaginal stenosis. Very essential is post-operatively, after 3 weeks, we go on telling her that she must apply local estrogen cream, which increases the vascularity and also adds the problem. Lastly, but not the least, we always keep the patient, especially in large fistula, after the suprapubic is done, on her prone position, so that the best possible bladder drainage is given to the patient as a result of that. And please, for all the people who are interested in fistula surgery, along with the Foley catheter, along with the suprapubic catheter, whichever you like it, you must continue antimuscarinic as much time till the time a cystogram is taken or is given. Thank you.
Thank you, sir. I also normally use an 8 or a 10 French Foley through the fistula, and I use it at extraction. But unfortunately, that day, normally our theater has a lot of, because we also run a pediatric surgery unit,
Correct.
we have a lot of 8 French, 10 French. It will be enough in plenty. Suddenly, when we went there, and I at that point when I asked, they said nothing is there. So I had to bring the vagina in front to. That's why I put a vicryl and suture. Otherwise, normally I use 8 French Foley, and sometimes even at the time of hydrodissection, it may puncture. I'll again put in another Foley. I really follow that.
So the Foley catheter has a tremendous importance.
Yes, sir.
Go deep, then you will puncture the balloon. That
True.
will give you an indication that your field of dissection is incorrect.
Yes, sir.
If you go in a correct position, you will never be able to damage the Foley catheter balloon, and that gives you a very excellent character that you are going. But very essential part that all the fistula surgeons must know, that we have to dissect at least 2 to 3 centimeters all around, and make sure that last 5 years I've been doing what is known as a suturing, when the edges go inverted inside, and that has tremendously improved the results together, almost above 98%. In fact, 15 days back, I did a fistula, which was 4 centimeters, a very large fistula, where you can put 3 fingers straight in the bladder. And the most important, that she was operated already 4 times. And she said that, can you do laparoscopy? I said, we will just see and evaluate you. We gave her 2 weeks of estrogen cream, and I did successfully vaginal repair. And I'll send you the clips of those vaginal surgery there.
Yes.
Thank you, ma'am.
Thank you, sir. Thank you.
Thank you.
Thank you, sir.
Thank you, sir. Thank you very much for your excellent guidance and your good words. I think we have just come to the close, and we had a very good, very practical session. To begin with, we had Dr. Muthulatha just giving us all the warning signals, and then how to approach and how to make it work easier as far as the bladder injuries is concerned. So the youngsters would have just taken the clue to avoid, and then also not to panic when they come across, and how to deal with that. Thank you, Muthulatha. Thank you for your nice words, and then crisp presentation to the youngsters, which will be very, very useful to them. We had an excellent global perspective and guidelines from Dr. Ajay Rana, and he has just given us very, very simple, basic things like, we got to talk to the patient, tell them what you're going to do, whether you're going to leave a pack, whether you're going to put a catheter, how long the catheter is there, not after the surgery, even well before the surgery, before you take the patient and counsel them to see that you have an adequate cooperation from them. And then he has also highlighted on the pelvic healthcare.com, and then said to just download all the instructions and then probably put it in our labor wards and consulting room and make sure that they are well educated. And it was really nice of him to come say that he will come back again on the January 22nd, the 3rd Friday, to demonstrate various aspects of this illuminated surgeries with an endoscopic camera. And last but not the least, we had an excellent presentation from our secretary, Dr. SEQUELAE, and she has shown ways in which it can be done very simply. And this is the art of vaginal surgery, which we possess and we should retain and we should maintain it to show the superiority to the others. Thank you very much. Thank you, all of you. And we hope to see you back again on 22nd of January. Thank you.
Thank you.
Thank you, madam. Thank you.
Thank you.
Thank you, sir.
Thank you, Madam Muthu.
Thank you, sir. Thank you so much.
Thank you, Ajit Vase sir. Thank you. We will have you back on another session. Thank you, Kalaivani madam, our director. Thank you. Thank you.
Thank you, madam.
Thank you. Thank you, Gopinath sir, for all the guidance and encouragement. Thank you, sir. Thank you. Thanks to Shield for their unstinted support always. Whenever we ask them for support, they are there always. Thank you, Balaji and entire team Shield and Chitrakala, who has been our tech support. Thanks to all, one and all. Thank you. See you in Jan.
Thank you very much.